Hi, good morning, everyone. Welcome to 147th CMAAO International Weekly Meeting. We are meeting on 24th of June, 2023. It is 9:30 a.m. right now. And we are meeting for all the CMAAO countries across Southeast Asia, Asia, and Oceania. Today, we are meeting on a very important topic, impact of STI on sexual health. And to present this topic, we have Dr. M. Balasubramaniam. He is joining us from Tamil Nadu. He is the recipient of Dr. Chacko Medal in MD Virology from University of Madras. He's a retired Deputy Director, Tamil Nadu State AIDS Control Society, former State Secretary, President and National Vice President of IMA, organized more than 100 programs on STD. He's a district vice programs on AIDS, safe blood transfusion of private practitioners of Tamil Nadu. And if anybody wants to join this session, they are free to join. They can join on the session of 818-8591-1572. This is a Zoom ID. You can just open the Zoom and you can come and ask your questions in the chat box. Sir, over to you.
Thank you, Saurabh Agarwal. At the outset, let me thank CMAAO and IJCP for providing me the maiden opportunity to join and speak about a topic. And let me first pay homage to Dr. K.K. Arwal, with whom I was acquainted with him for more than 2 decades in IMA. Dear friends, the topic I had chosen is impact of sexually transmitted infections on sexual health. You know, everyone is concerned about health. And WHO defines health not only as absence of disease, but physical, mental, and social and spiritual well-being. And one aspect of health is the sexual aspect with which many of the people, especially people from 15 to all the years they are living in this world, they are concerned about having a good sexual health. Slides. Kindly excuse me. More than 1 million, that is 10 lakh sexually transmitted infections are acquired day worldwide. Yesterday it was 23rd, and by the dawn of 24th of June, we have 10 lakhs people who have acquired sexually transmitted infection last night or last day. Each year, there are estimated 374 million new infections. We have only 365 days in a year, but the number of STI outscores the number of days in a year, and we have 374 million new infections with one of the 4 curable sexually transmitted infections, namely the chlamydia, gonorrhea, syphilis, and trichomoniasis. More than 500 million people in the age group of 15 to 49 years are estimated to have genital infection with herpes simplex virus, that is HSV type 1. Human papilloma virus infection, HPV infection, is associated with over 311,000 cervical cancer deaths each year. About 1 million pregnant women were estimated to be infected with syphilis in 2016, resulting in over 350,000 adverse birth outcomes. STI have a direct impact on sexual and reproductive health through stigmatization, infertility, cancer, pregnancy complications, and can increase the risk of HIV infection. If a person has sexually transmitted infection, that is an ulcer, he is more prone to get HIV and more prone to transmit HIV also. Drug resistance is a major threat to reducing the burden of STI worldwide. More than 30 different bacteria, virus, and parasites are known to be transmitted through sexual contact, including vaginal, anal, and oral intercourse. It is not only the vaginal intercourse which results in sexually transmitted infection, even anal and oral sex can cause sexually transmitted infections. Some STI can also be transmitted from mother to child during pregnancy, childbirth, and breastfeeding, especially HIV. 8 pathogens are linked to the greatest incidence of sexually transmitted infections. Of these, 4 are currently curable: syphilis, gonorrhea, chlamydia, and trichomoniasis. With a single injection or single course of tablet, we can cure these 4 diseases. The other 4 incurable virus infections like hepatitis B, herpes simplex virus, HIV, human papilloma virus are incurable. In addition, emerging outbreaks of new infections that can be acquired by sexual contact, such as monkeypox, Shigella sonori, Neisseria meningitis, Ebola, and Zika. Even Ebola and Zika can be sexually transmitted, as well as the re-emergence of neglected sexually transmitted infections such as lymphogranuloma venereum. These herald the increasing challenges in the provision of adequate service for STI prevention and control. So if you see the world map, no continent is free from sexually transmitted infections. If we take our CMAAO, Asia things, we have 13.8 cases of chlamydia per million, 11.4 cases of gonorrhea, 0.9 cases of syphilis, 13.2 cases of trichomoniasis. So before the advent of HIV, whichever countries, whichever continents were having a high prevalence of sexually transmitted infections, now they have the highest prevalence of HIV, especially the South African countries, even our Asian countries like India, we have the higher incidence of HIV. Right. Let me come to this. See, sex is a basic human urge, especially after adolescence, when the boys, they have the surge of testosterone, and the girls who have surge of start menstruating, estrogen and progesterone, they have the secondary sexual characters with them. And in boys especially, they experience a new phenomenon called erection of penis. Till then, they were using the penis only for urination. Now, they have a different purpose or additional purpose. This knowledge, they do not get from the schools or syllabus or scientifically. It is from the peer influence. Tell your friend, I will tell you who you are. So birds of same feather flock together. When these teenagers, and with especially the marriage being postponed nowadays, they want to finish not only graduation, they want to finish post-graduation, go for a job, earn well, and settle in life, and then get married. So by this time, they will come to 30 years or 35 years. So till then, how they can control this phenomenon of sex? See, sex is a physiological process, just like urination, defecation, everything. But there is no pleasure involved in urinating or defecating. Whereas when they involve in sex, when they have ejaculation, they have the pleasure called the orgasm. Even the orgasm can occur in women also. So the boys in the teenage and third decade of life, 20 to 30 years, because of postponement of marriage, they want to experience or experiment with sex. So with a peer influence, they have sex with commercial sex workers or people known to them, and they have sex. So during sex, they get the pleasure, but the next day morning, they get frightened. They would have heard about sexually transmitted infections or AIDS. So they become curious and go to bathroom and examine the genitalia. So far, they have not retracted the prepuce and cleaned the smegma. But here, after having a sex, they become guilty and look at the genitalia. 20 to 30% of the people will have pearly penile papules or ectopic sebaceous gland or Fordyce glands. So they presume this as a sexually transmitted infection. No infection can occur within 12 hours of having the contact. So they become panic. They presume that they have acquired a sexually transmitted infections. And this is called venerophobia. And they usually do not discuss with their parents. Sometimes they discuss with their friends. The friends, sometimes they take them to a general practitioner. And many times the general practitioner himself is not familiar with various venereal diseases or sexually transmitted infections. He may get confused. He may presume this as what and refer to a sexologist or a venereologist for treatment. So when this poor guy, when he comes to a sexologist or venereologist, the venereologist takes the history, examine, and he says, what you have is not a venereal disease. This condition is called venerophobia. Venerophobia is defined as an exaggerated or irrational fear of contracting venereal disease following an isolated or multiple episodes of sexual intercourse. Being a lesser known entity in dermatology, very less cases are recognized and reported. I don't think even the international nomenclature for various diseases includes this condition, venerophobia. It is a condition that is observed exclusively in males. In females, most of them are asymptomatic. They cannot see the inner parts of the genitalia. They're just like boys seeing the penis externally. And moreover, women are bothered more about pregnancy, whether they would have become pregnant after this sexual unprotected sexual contact. So they are more bothered about pregnancy rather than the sexually transmitted. Sir?
Sorry, sir, go ahead. Somebody just unmute the background.
So I'll answer in the end. I'll answer your queries. So there is a specific incubation period for various sexually transmitted. I told you there are 30 diseases, each one caused by a microbes. And the incubation period is the interval between the entry of the organism and the onset of signs and symptoms. Some of the diseases, they have a short incubation period, like chancroid, gonorrhea, even trichomoniasis. Syphilis has got a medium incubation period of 10 to 90 days. Chlamydia, 14 to 21 days. HIV, 14 days or even little longer. Genital herpes, 2 to 14 days. Hepatitis B, 20 to 42 days. Scabies, you may wonder whether scabies is a sexually transmitted disease. All contagious disease are sexually transmitted because the contact is more intimate and more prolonged in sex. So contagious disease are also sexually transmitted. And genital warts, it may range from 90 days to 6 months or so. So there is no sexually transmitted within 24 hours. It takes at least 24, usually 2 to 3 days in chancroid, gonorrhea, and herpes. Rest of them, they have incubation period is 2 to 3 weeks. Each sexually transmitted disease has what is own sequelae. The sexually transmitted infections are global and national health priorities because of their effect on women and infants and interrelationship with HIV and AIDS. STI can cause a variety of long-term health problems. The sequelae of STI includes pelvic inflammatory disease. See, the gonorrhea and chlamydia, which causes cervicitis, ascends up and into the uterus and to both fallopian tubes. So it is called as bilateral salpingitis. When bilateral salpingitis, when they heal, sometimes they can occlude the fallopian tubes and cause infertility. Bilateral tubal block can occur. When she has got active meningitis, if pregnancy or fertilization occurs, which usually occurs in the fallopian tubes and later on moves into the uterus, here because of active salpingitis, it will not move. The embryo will not move and it will start growing in the tube. So this is called tubal or ectopic pregnancy. And as you know, the papilloma virus are the main culprits for cervical cancer. Perinatal or congenital infections in infants born to the infected mothers, they can. I think I can narrate in a separate lecture or in newborns. So, to treat various sexually transmitted infections, the CDC, Center for Disease Control, or in India, we have NACO, National AIDS Control Organization. They have come out with syndromic management, where not only venereologists, even any doctor, or to the extent that even any nurse or paramedical people, if they follow this flow chart and take the history and follow the flow chart, they can treat. So, for example, genital ulcer, non-herpetic. When do we say non-herpetic? When the ulcers do not start as vesicles. In herpes, it always starts as vesicles and rupture and forms the ulcer. When it is not vesicles, genital ulcer, single or multiple, painful or painless, burning sensation in the genital area, enlarged lymph nodes. We give benzathine penicillin 2.4 mega unit, that is what 24 lakhs IM after test dose, or azithromycin 1 gram single dose. If the person is allergic to penicillin, doxycycline 100 milligram BD for 15 days and azithromycin 1 gram single dose. So the azithromycin will take care of chancroid, and benzathine, penicillin or doxycycline will take care of syphilis. So it comes in a kit form with specific color code also. So it is the tablets are given free of charge in the government hospitals. Genital ulcer herpetic, genital ulcer or vesicles, single or multiple, painful, recurrent, burning sensation in the genital area. We give acyclovir 400 milligram thrice daily for 7 days. So when the patient comes with vesicle before rupturing or after rupturing with the history of vesicles, we make the diagnosis of genital ulcer herpetic and give acyclovir 400 milligram TDS for 7 days. Same thing with urethral discharge. We give azithromycin 1 gram and cefixime 400 milligram. Azithromycin will take care of chlamydia and cefixime will take care of gonorrhea. Vaginal discharge, usually vaginitis is caused by trichomoniasis, candidiasis or bacterial vaginosis. Here we give secnidazole 2 grams statum and fluconazole 150 milligrams statum. Where it is a lower abdominal pain with PID, usually it is gonorrhea or chlamydia. We give cefixime 400 milligram, metronidazole 400 milligram BD for 14 days, doxycycline 100 milligram BD for 14 days. So when the infection has ascended into the uterus, fallopian tubes and the abdominal cavity, we don't use single dose, we use medicine for 2 weeks. So for pubo, azithromycin and doxycycline. Azithromycin will take care of chancroid and doxycycline will take care of lymphogranuloma venereum. Bilateral scrotal swelling, epididymoarthritis. We give azithromycin to 1 gram to take care of chlamydia and cefixime 400 milligram to take care of gonorrhea. So, so the treatment of various sexually transmitted diseases are very simple. And we have all the government hospitals and some of the private hospitals empowered to give the medicine free of charge. So the same friend who had taken this new friend to a commercial sex worker takes him to the health facility, and in the health facility doctor sees and says give the diagnosis and give the treatment and cures him almost to the point of cure. Not only that, we here when the person comes to the health facility, we do little counseling and tell about the various sexually transmitted infections and the chance of getting the HIV infections, incurable HIV infection. And also tell now HIV infection has become a chronic manageable disease rather than a killer disease. So we always advise them A. A is abstinence till marriage, abstinence in sex till marriage. Friendship should not cross boundaries at any time. So A is for abstinence in sex till marriage. B is for be faithful to the spouse, let it be husband or wife. So the marital relationship should be mutual, trusted and long lasting. So B is for be faithful to the marital partner. C, for people who cannot listen to A, that is abstinence before marriage, and B, being faithful to the marital partner. If they want to have premarital or extramarital contact, they should always use condom. Never condom condom. Because condom gives about 99% protection from various sexually transmitted diseases, including HIV. So when they properly use the condom, the chance of getting the disease is very, very remote. So C is for condom. And also we have D. Even if they are unfortunate and they have sex unprotected and get the HIV or any of the disease, we have the treatment. Even HIV with the antiretroviral drugs, it has become a chronic manageable disease. And the drugs are given free of charge in the government hospitals, in the district headquarters and medical college hospitals in India. So I initially told about venerophobia, especially when the teenage people and early 20s and 30s age group boy, when they have a desire or a libido, when they have sex and they fear about sexually transmitted infection. Once they come to know about the various health facilities because of counseling or approaching the health facility, they now know that almost sexually transmitted disease can be avoided by using condom. And even if they get the disease, they can approach the health facility and get cured of the sexually transmitted infection. And even in women who is more bothered about pregnancy, emergency contraceptive pills are available. which they can take within 24 to 48 hours of after exposure and prevent becoming pregnant. So this facility or the better knowledge results in promiscuity. Promiscuity is defined as indiscriminate indulgence in sex, not bothering about the partner, place, or time of sex. Because they know they can use condom and have sex, or even if they get the disease, they can approach the health facility and get the treatment. So promiscuity, even though it is a late phenomena occurring in these people, these people indulge in premarital or extramarital sex for a long time. And sometimes when they have unprotected sex with the extramarital contact and have marital contact with their spouse, they can transmit this infection to the innocent wife also. So promiscuity is little dangerous in the sense that they can get the infection and pass it on even in the incubation period of the sexually transmitted infections which they may sometimes get. So the promiscuity phenomenon thing. So my thing in what I wanted to stress in my lecture is initially there will be a phenomenon called venerophobia, and when they get the disease and get the treatment and get the counseling, the fear of venereal disease may go off, and these people may indulge in promiscuity, frequent sex. So I would like to project 2 or 3 more slides before taking up the questions. See, we do not have a postgraduate course in sexual medicine, especially in India. And the undergraduates, they do not have the lecture about the sexual medicine also. So there is a lacuna in the curriculum of the medical education, which has caused the quacks, the people, unqualified people, to plunge into the sexual medicine and come out in the various things, media, yes, both television and social media, and fool the gullible public, and they make money without treating them with the scientific knowledge. So our IMA Tamil Nadu state, we have started a certificate course in sexual medicine. These are the topics which we cover: introduction, basic values in sexuality, response cycle, psychology of sexual response, hormones in sex, investigation, counseling, psychotherapy, sex therapy, sensate focus, pharmacotherapy, coitus posture, consummation, sex factors helpful in treating infertility, male infertility, hypoactive sexual desire, sexual aversion disorder, male erectile disorder, male orgasmic disorder, female sexual disorder, female orgasmic disorder, painful coitus, sexuality education, and much more, like even POSCO Act, prevention of child sexual abuse. So the course coordinator is Dr. Narayan Reddy, the famous sexologist from Chennai, and he is also the chairperson for the Asian countries of sexologists, and myself. Eligibility is IMA CGP life membership. Course fee is 25,000. Duration of course is 6 months. First and last class exam will be offline, that is in person at Chennai. Class 2 to 9 will be online twice a month. And for admission, they can contact the email imatamilnadu@gmail.com or cgpv imatamilnadu@gmail.com. So if there is any questions, I come to know that all are stalwarts in their respective countries, and many of them, what I had given is only for the fresh general practitioners or to the public who sometimes who may also attend this. And if you I would like to get the information about the STI in their respective countries.
Thank you, sir. We'll close the slides now. So thank you for your wonderful presentation on the very important topic. Now we will open the forum for the question answers. Does anybody has questions related to the topic? Yes, Dr. Jonkar.
A very nice lecture. I think it is very sensitizing for all people. Maybe we will circulate this video to all medical colleges so that at least those interns who do basic MBBS should understand this is a nationally important topic. My question was after the COVID and all that, and people doing, say, getting fascination of doing oral sex. Do you have additional viral infection which are STD?
Yeah. See, we thought during COVID, STI or HIV will come down. Initially, it did, the thing. But when people were confined to the houses or when they started working from their home and they had more free time and extra time and money and the STI and HIV which were coming down in the initial part of the COVID, now they have started ascending. Not only that, many people did not approach the health facility who are already suffering from HIV. There were many dropouts. The PLHA, people living with HIV or AIDS, could not travel in the initial years of COVID. They cannot come to the hospital to get the monthly quota of free medicines. They did not take the medicines. So many of them became defaulters. Now, with the COVID coming down and other things, so the health facilities, mainly we call it as ART center, antiretroviral centers, they have started working full time. They are contacting the people who are not reported. Some of them might have died also of the COVID opportunity infection. They usually do not die of HIV. They may die of opportunity infection like tuberculosis and other. So we are finding it difficult also because of the COVID. And definitely it has not taken the fear part from the public. Even some of the countries, they have reported more deliveries, pregnancy and deliveries during the COVID time, rather than the things.
Thank you.
So there's a question on the Facebook. It says that is it true that there could be no symptoms and still there could be an STD or STI?
Yeah. We call it as not asymptomatic, we call it as latent. Latent means hidden. See, some syphilis causes ulcer from the 9th day to 19th day. If the person has got phimosis and if the ulcer develop in the inner aspect of the prepuce, you may not notice it because it is painless. So same way with HIV. So then he goes into the latent syphilis and develops secondary syphilis. The secondary syphilis, we have seen skin rashes. They are non-itchy. The beauty of syphilitic skin rash is bilateral, symmetrical, non-itchy, macular, papular squamous lesions. So since it is non-itchy, you will not come to the medical, approach the doctor to get it treated. So you will skip. It may heal within a month or a few months. And he goes and develop neurosyphilis, cardiovascular syphilis, gamma, like that, ocular syphilis. So a person can be asymptomatic, can harbor the infection. And up to 2 years, he is infectious. After 2 years, he may not be infectious to the sexual partners. Same way with the HIV. HIV virus enters through sexual contact. It does not cause any lesion over the genitalia or mouth immediately after the window period. We call it as window period of 3 weeks to 3 months. Only the blood test becomes positive. Sometimes the fever is mild and ignored as a viral fever. And it goes into the asymptomatic phase or latent phase and develop the opportunity infections when the CD4 counts gradually falls, especially when it falls below 350, the develops opportunity infection and manifests the opportunity infection. The main things of 3 cardinal things of more than 10% of weight loss within a month, diarrhea more than a month, and fever more than a month occurs only at the end stage of full-blown AIDS. Rest of the times it is only the opportunity infections which bring these people to the health facility. So, and especially in women, the vagina and cervix are inside of the thing and they cannot watch it even wash the genitalia. And their white discharge is almost normal in all women. 1 teaspoon of white discharge in a day is considered as a normal. Only when it is more or swelling and other symptoms like pain, itching are there, we say that white discharge. So many times they ignore this. And what if they occur in the cervix? After a few years, they may turn malignant. The cervical cancer can be there. So many times it is asymptomatic one.
There's a question by Dr. Khatri. How do you manage HPV?
Human papillomavirus. See, even though the human papillomavirus or common skin wart is almost the same like genital warts, both are not synonymous. The strain is different. There are more than 30-40 strains of human papillomavirus, and many of them cause the benign common skin wart. Whereas in genitalia, the strain is little different. And the appearance also, the common wart will be of the same color as the skin. Whereas the venereal wart, it will be reddish because it is non-keratinized and we can see the blood vessels inside the wart. So they are either reddish or pale in color. And the treatment also, the treatment which we give for common skin wart, this one, acetic acid, salicylic acid, they are not, they should not be used for this venereal wart. And the same medicine, podophyllin, which is used for venereal wart, used for skin wart because they are not common skin wart is keratinized and podophyllin will not penetrate through the keratin layer. And this, so we use either chemical cautery or electrical cautery or laser thing. We cauterize these warts and make it fall off. So treatment is very simple, especially when the warts are seen outside the genitalia, with 3 or 5 applications of podophyllin or the things we can control human papilloma. So in women, the cervicitis is cervical cancer is most likely due to human papilloma. That is why the vaccine which is used for human papilloma virus used to prevent the cancer cervix in women. As for, we venereologists, we do not give this vaccine for the promiscuous people to prevent this one, developing the venereal wart, because we can treat them if they get, or advise them to use condom. So this is in a nutshell human papilloma virus. I would like to speak separately on human papilloma virus as well as herpes simplex virus also.
Okay, there's another question from him. Belantis DD management, please guide.
Balanitis. The inflammation of the glans penis is called balanitis, and inflammation of the prepuce or the foreskin is called fasciitis. Usually occur together, and they are called as balanopasciitis. What is required is only genital hygiene to prevent this balanopasciitis, especially the teenagers, where at the age of 14 or 15, when they start secreting mucus secretion on the surface of the prepuce, we call it as smegma. It is secreted by small tiny glands called Tyson gland on either side of the frenulum, that is thin tissue occurring in the 6 o'clock position of the prepuce, where it joins the glands. So, the even before marriage or sex, these teenagers should be advised to retract the prepuce, pour a mug of water, clean it with 2 fingers, and remember to pull back the foreskin immediately. If they are not able to retract the foreskin, is called phimosis. And phimosis may not do much harm in young children and other people. But when they have sex thing, it may either result in tear or it may move backwards and they can become edematous and they cannot be pulled forwards. We call it as paraphimosis. Then it becomes an emergency to reduce the edema by puncturing with needle and pulling back the prepuce, or do the dorsal slitting or even circumcision. So the balanopasciitis can be due to many of the bacteria and things. Sometimes, many times it is due to the infection of the smegma by Fusospiraceae. So it will produce superficial ulcers. Sometimes venereal STI like gonorrhea, chlamydia, trichomoniasis, even candidiasis, they can cause this balanopasciitis. So we have to treat the cause. First take a smear and examine whether it is due to Fusospiraceae or due to sexually transmitted infections. I told you for gonorrhea we use cefixime for 400 milligram stratum. For chlamydia we use 1 gram azithromycin. For trichomoniasis we use 2 grams of secnidazole. For candidiasis we use 150 milligram of fluconazole and treat it. For Fusospiraceae, the secnidazole or metronidazole is helpful, and all Fusospiraceae also will be destroyed by metronidazole. So balanopasciitis, it is easy to treat, but when it is left untreated, it may lead to even carcinoma of the penis, smegma collection and other things. Smegma is carcinogenic and it can lead to carcinoma of the penis also. So balanopasciitis can be treated easily. Usually we give 1 gram of azithromycin, 400 milligram of cefixime, 2 grams of secnidazole, and 150 milligram of fluconazole as a syndromic thing. Even herpes sometimes can cause, and in that case we use acyclovir cream.
Dr. Khatri, would you like to unmute and ask question? He has another question. Please guide us about indication using tacrolimus in venereology.
These are new drugs. In syndromic management, we do not use the new drugs, but these things can be used. As a dermatologist, we can use it and leave it to the treatment of the specialist. Many times, even the fungus, now there is a phenomenon called tight dress syndrome. People using jeans, both male and female, when they use these jeans and there is no free circulation or breathing by the things. And moreover, they use synthetic undergarments. So they get this fungus infection, especially tinea bruris. They are very much prevalent now, even in unmarried as a contagious disease.
Hi, do we have any other questions on the floor? Hi, Dr. Akhtar, Dr. Kazi, Dr. Naidu, Dr. Prakash.
Hi, good morning. Hi, excellent
Nothing from me,
presentation. Can I ask prevention issue? The treatment of STI syndromic management is free. What about the condom distribution is also free? And how is the utilization of condom in the population?
Yeah, actually, before the advent of and availability of antiretroviral drugs, we were doing condom promotions, and we were distributing condoms in all STD clinics and other things also. We had also condom vending machines in many of the hotels, or bus stands, railway station. Also, we had free condom vending machines, which we carried out through non-governmental organizations, through NACO and respective state AIDS control things. We were advocating this free condom, and we were distributing free condoms.
Dr. Ravi?
Sharab.
One
This is-
question, Saurabh.
Yeah, Dr. Ravi. Dr. Basil, just give me a second.
Dr. Balasubramaniam, thank you very much for your excellent talk. There's one part of your slide I saw that the best thing to do is avoid sex before marriage. But unfortunately, if you see the present generation, I don't think that sort of a thing is going to be possible. So definitely there's going to be transmission quite rampantly.
Yeah. So, even though we talk about culture of India and other Asian countries, which we have been having it for centuries, now because of globalization and influence of the Western world, as not only the pizza and burger have come to India, but all the other things have come to India also. Now, boys and girls mingling is not that much forbidden. And sometimes even they give high five, so many other things, hug, and do so many things, even in the open space or public areas. So touching is not also considered as a sin or something in things. But nowadays, these people have become more clever. They know things. Many people, they know how to safeguard themselves. They safeguard themselves and avoid certain intimacy situations of being alone, male and female alone. Or when they understand each other and give consent, and they may have. See, what law prevents is sex should not happen by compulsion, coercion, or assault. And if it happens with both the persons concerned, and it is not a punishable offense. Only thing is, even a person below 18 years cannot give consent. So he or she is considered as not an adult, and this act comes, POCSO Act, Prevention of Child Sexual Abuse Act comes. So many people they know about it, and they the influence of alcohol in India, most of the states they have free availability of, not in the sense, even though it is available for money, it is available everywhere. And there are certain party drugs. Now, a lot of parties happening on Saturdays. Where is the party like that on Saturday? So party drugs are also there. So a person who is about to get spoiled, or we cannot even use the word spoil, things, they may experience and come out of the things. Now, there is a very old saying, chastity is lack of opportunity. It is never a thing. Any person can indulge in sex, even premaritally or extramaritally also. Only thing is he should know about the things. He should be sensitive. Now we have started including the curriculum also, college curriculum, higher education curriculum. So they should be sensitized before the age of 14. And after that, they can take the decision and thing. Then the effect and after effects rest upon the individual, not on the community or the government.
Dr. Kasi?
Yeah, thank you, Sarab. It was a wonderful talk. And my question is your comment about a routine male circumcision as a preventive procedure. What's your comment about that? I mean, taking circumcision as a preventive procedure, will it be good to have male circumcision in the early age before adulthood?
So this we have seen in African countries. Even though when HIV was prevalent 30 to 40%, those communities which were Christian things, the prevalence was heavy. But in Muslim pockets, where they undergo circumcision in the African country, the HIV prevalence was less. So a lot of research was done, and it was found in uncircumcised person, when he has sex, when the to and fro movements are there, in the inner aspect of the prepuce also get exposed, and there is micro aberrations, if not visible things, micro aberrations are there. This HIV present in the women, even though they are non-motile, they just cling to these micro fissures, and the target glands called CD4, they are very much available on the inner aspect of the prepuce. So the virus easily clings into these Langhans cells of CD4. Once it enters into the CD4, it cannot be destroyed by drugs. Even we do not have virucidal drugs. It is only static things. So seeing this, many of the Christians in African community, they have had this circumcision voluntarily, and government also provided them for circumcision. So this circumcision is described as an invisible condom. It is as if they are wearing the condoms, even though they are not wearing the condom. If they are circumcised, the chance of getting the HIV infection is less, because the thing, and it's what's called as an invisible condom. But in country like India, or the Christian, where the Hindu-based or the Christian-based countries, it is very, very difficult to convince them to protect, just to get rid of this HIV. do circumcision. So none of the government in India, they have not propagated this circumcision. But if you ask me personally, circumcision is good in the sense, it not only prevents the acquiring HIV, even for sex, for premature ejaculation, circumcision is good. Once the glands is exposed and it is contact with the undergarments in circumcised people, desensitization occurs and this premature ejaculation comes down drastically. So for premature ejaculation, we were advising anesthetic agents like xylocaine jelly, or where we were doing circumcision. So in both the ways, circumcision is a sign. I feel that it is a scientifically approvable things which can be done.
Okay, thank you.
So we have any other questions on the floor? Okay, so sir, thank you so much for your wonderful session and your wonderful time you have given it to us. It was a very, very helpful session for all of us. The session is live on social media. So with this note, we would like to end today's session. And we again thank you for your guidance. And I also thank all the members who are joining in here and patiently listen to the session and ask questions. So with this note, we will end the session. Thank you everyone for joining in. See you again next session. Thank you.